Okay, well, welcome everyone to Pediatric Teaching today. I will make a start. Today I wanted to talk about poisoning in children. It's quite a common problem in children in all countries, presenting to emergency departments and being seen in children's wards and in intensive care units. So it's worth us knowing about how to manage acute poisoning in children and to know some of the general aspects of management and also some specific aspects of looking after children who've had common poisons, poisons that are common at least to low and middle income countries and tropical regions where certain poisons are a bit different to other areas of the world. Yeah, poisoning is very common. It's a leading cause of accidental injury and death. If you think about the so-called accidental causes of childhood morbidity and mortality, then there's road trauma comes first, then drowning, then burns, then falls, and then poisoning. So it's up there in the top 5 causes of accidental injury and death in countries all throughout the world. But the patterns differ across the world depending on the access to available poisons. In some countries, poisoning is more the ingestion of medicines that are available within a household, and then in other countries, poisons are a bit more likely to be toxic chemicals that are stored poorly. Most countries have had a public health approach to this, and the countries that have been most successful have done a variety of things, such as limiting or banning certain products. And it's very important to limit or ban products that are dangerous to children and to enforce safe packaging and warning labels on any products that are sold. Parents and households, farmers need to be educated about poisons and about basic safety measures. And then, of course, lastly, what countries have done is to improve clinical management of childhood poisoning. It goes along with all the other things, very important to include to improve the initial management of childhood poisoning because it can save lives. So today we're mostly going to talk about the last point about clinical management of childhood poisonings. But I just wanted to say that there are hundreds of poisons, really, many hundreds of potential poisons, and we can't possibly know everything about all of them. So firstly, you need to understand the principles, and then you need to have resources. And I think there's some general principles that I want to go through to start with. One is a bit about the epidemiology, like who gets poisoned. There's not many poisonings occur in infants, in young infants, unless they're induced poisons by given inadvertently or deliberately by a caregiver. Most poisonings occur in children in the 1 to 5 year age group, and most of these are accidental, or at least the poisonings that do occur in that 1 to 5 year age group for 2 reasons. One, because they're accidental, and 2, because of a lack of safety or parental supervision, often a lack of precautions. In the 6 to 12 year age group, these poisoning is less common, but it often includes drinking a poison from a bottle that's wrongly labeled or is unsafely stored, such as a herbicide or a insecticide in a fizzy drink container in a garden shed. That's a potent cause of poisoning. If poisons are held in inappropriate containers within reach of children. And then beyond 12 years, then in the teenage and adolescent age group, then we see more poisonings from deliberate self-harm or sometimes accidental drug overdose in adolescents who are embarking or taking part in recreational drug use. But a lot of poisonings occur because of deliberate self-harm in that adolescent age group. And sometimes because it's deliberate self-harm, often there are much more consequential poisonings than occur in the 1 to 5 year age group, where 1 or 2 tablets may be taken, potentially of a dangerous medication, but not 10 or 20 tablets in when there's been deliberate self-harm among adolescents. So we need to be aware of the different types of poisonings that occur at different age groups. Young children are very curious, and toddlers always go hand to mouth. If they pick up an object, then it goes into their mouth, no matter how dangerous it is. So these are some of the reasons why young children and toddlers get poisoned. And as I said, the improper domestic storage of household or garden products that are not recognized as being poisonous by parents or by other caregivers is a potent source of poisoning. And I want to go through some of these. The common accidental poisons that we see in children are, and as I say, in different countries, there's a different list of the top 10, certainly in different countries, but the common poisonings include kerosene or any other petrol or any other hydrocarbons that might be stored in a shed, and perhaps in a inappropriate container in a Coke bottle or something like that. Cleaning products will be in the house often, and they can be acidic, but they're more likely alkaline, and they cause a specific sort of poisoning. Insecticides, again, if they're inappropriately stored, then young children can get their hands on a bottle of insecticide and drink it. And they're mostly organophosphates, not all, but mostly organophosphates. So there's been a series of poisonings that have occurred from mosquito coils, pyrethrum poisoning that occurs from children ingesting small particles from a mosquito coil, and that can cause a specific sort of poisoning. Paracetamol is one of the most commonly ingested poisons because it's just so freely available around households, and also can be bought over the counter, and some adolescents know it's very dangerous and it can cause injury or death. Chloroquine is another, for many decades, has been a common cause of poisoning, either from deliberate self-harm among adolescents or inadvertent ingestion of 1 or 2 tablets by young children. And then other household medications, increasingly as more and more medications are being prescribed, be they antidepressant medications or antihypertensive medications, antipsychotic medications, all those sorts of household medications are become increasingly common causes of poisoning. And often it's just taking 1 or 2 tablets or even a few tablets because the child wants to be more like their parent who they see taking the medication. Then there's some poisons in the garden or in the bush. Certainly wild mushroom poisoning, it can cause death in children. And oleander, that plant that's a tree that's in the garden, can be a potent source of poisoning. Many other plant poisonings, digitalis and other things, can lead to a toxidrome from the poison. And then there's some other environmental things such as carbon monoxide, and sometimes when there's defective heating sources within a house, then carbon monoxide can be a poison, or even from a motor vehicle. There can be carbon monoxide leaking into the cabin of a motor vehicle, and it can cause toxicity. And then lastly, well, not lastly, because there's hundreds and hundreds of poisons, but another common cause of poisoning in children is iron. And as you probably know, iron can lead to severe gastrointestinal disruption, mucosal erosion, perforation of the bowel, stricture formation, etc. So iron, even though it's often described as a sort of vitamin, is a very toxic poison and needs to be cared for in the same way as we care for any other medication. But often it's considered just something you buy over the counter, iron supplements for people who have anemia, and children get to it and ingest a number of tablets and then have the consequences of that later on. So they're common accidental poisonings, some of which we'll go through today. Again, we don't have time to go through them all, or even all the other medications, but just back to some main principles. the first step when you see a child is to make sure that it's safe, and that is medically safe. Often there are unusual circumstances in which the child took a poison, either they were inadequately supervised or they there may have been a poison put in the wrong container. But those circumstances can be resolved later, and our job is to address medical threats first. And there are general medical threats to all sorts of poisonings, and any child who's taken a poison might have an airway, breathing, circulation, or conscious state threat. And that might be a general threat. They may be unconscious and therefore have an airway problem, or they might have breathing difficulties or whatever. They're general threats that we can address easily in a triage and emergency situation. Then there are some specific threats based on the type of poison that also may affect the airway, breathing, circulation, or the conscious state. And then sometimes the poison will affect other organs, such as an acute kidney injury, failure, or it may affect the skin or the eyes, lead to burns on the skin or the eyes. There are specific threats related to that particular poison. So it's useful to have a way of dealing with the first general medical threat a child has, and then understand what type of poison they've taken, how much, etc. And then you can understand the specific threat related to that particular poison. All the management of seriously ill children benefits from having a structured approach to management, and the 10 stages of management that we talk about: triage and emergency treatment, taking a history and doing an examination, doing a laboratory identifying the main diagnosis and other diagnoses, providing treatment and supportive care, and monitoring and discharge planning. They're all relevant to a child who's ingested poisons. And so, for example, at triage, again, this is about assessing their airway, their breathing, their circulation. It can be quite basic and quite general. You take a brief history of the presenting problem, you take the temperature and weigh the child, you listen for obstructed breathing, you look for cyanosis and signs of respiratory distress, such as chest indrawing or tracheal tug, and measure the oxygen saturation. With the circulation, you feel the skin, temperature of the hands and feet, feel the pulse volume, and check the capillary refill time, measure the blood pressure if you can. And for the conscious state, assess the level of lethargy and the level of interaction. This is the way we assess do triaging for any child who's seriously or with any problem, and it applies also to poisons. But specific to poisons, you really do need to know what poison was involved, because there are different threats from different poisons. You want to know what poison was involved, in what quantity, when did the exposure occur, and could other poisons have been involved? Sometimes there's more than one poison. If a child has picked up a handful of medications and just taken them, there may be more than one poison involved, and therefore there may be more than one toxidrome. The child may suffer from the toxidrome, which is the health, the organ system consequences of taking a poison. There may be more than one, and they may overlap quite a bit. When you do know the type of poison, then you can revise your assessment about the specific airway, breathing, circulation, conscious state threats. This is very important. If you know the poison and you know roughly the dose, then you can know what you might face, or the child might face. So, for example, as well as the general threats to the airway from an impaired conscious state, if a child's taken a caustic ingestion, such as they've taken a drain cleaner or a household cleaner, then they may well have airway burns and swelling. That might be the major problem. Or if they've taken benzodiazepines, some diazepam, some Valium that's lying around, then that will cause central nervous system depression and may lead to airway obstruction. For breathing, for example, if a child's drunk kerosene, taken an ingestion of kerosene or other hydrocarbons, then they may cause acute respiratory distress syndrome or a pneumonitis. If they've been exposed to cyanide or carbon monoxide, then that causes very severe hypoxemia. If they've taken ingestion of aspirin, that causes tachypnea, central derived tachypnea. Regarding their circulation, for example, if a child's taken beta blockers from a parent or a grandparent, then that will cause bradycardia. ACE inhibitors like enalapril causes hypotension from vasodilatation. If a child's taken oleander, like the leaves of an oleander tree, or they've taken digoxin, the medication lying around, it often causes heart block. So again, there's specific airway, breathing, and circulation risks from many different poisons. Or if they've, in terms of conscious state, seizures can occur because of tricyclic antidepressants or theophylline or isoniazid. They all cause seizures. If a child's taken a number of tablets of any of these, they may have seizures. Lead poisoning or sedatives cause CNS depression, for example. So there's, again, knowing the specific poison or the specific medication can really help you understand the specific threat that you need to observe for in the next 4 to 8 to 24 hours and several days beyond. Not only are there sometimes with some poisons airway, breathing, circulation, or conscious state threats, there are also threats to other organ systems, and that again is why you need to know the exact poison. So there are threats to the blood, so hematological threats. Mothballs, naphthalene causes haemolysis. Lead poisoning causes anemia, for example. Ethylene glycol causes acute kidney injury. That's the main threat. With paracetamol, children get liver failure if they've taken a toxic dose. They don't get it immediately. They'll get it several days later. We'll talk about paracetamol. With wild mushrooms, they are prone to liver failure. Solvents can cause liver failure. So again, knowing the specific poison becomes very important. The first stages of emergency management are to prevent absorption of the poison. And that can be because if, for example, if a child spilt poison over their skin or in their eyes or their mucous membranes of their mouth or anywhere else, then to clean it off is very important. Wash or irrigate the skin if there's a poison that's likely to be irritant to the skin. And then to prevent absorption of the poison from the gastrointestinal tract. Now, what you use and whether you do this depends on what you have available. It depends on the timing of the ingestion and when you see the child. It depends on the type of poison that was ingested. It depends on whether the clinical state of the child when they first present. So there's a number of things that can be done. First of all is activated charcoal. That's probably the most used medication or most used product to absorb many drugs. I'll talk a bit more about that shortly. Another something that is sometimes used is gastric lavage. That's really only effective if the child's taken the poison within an hour of you being seen. If it's beyond an hour, then usually the stomach is, the poison has passed the stomach. Also, gastric lavage can be very dangerous if a child is poorly conscious or if they've taken a poison that's likely to make them unconscious. And so these days, gastric lavage is rarely indicated. It's largely only indicated if a child has taken a poison very recently and if their airway is very protected. But activated charcoal can be a better product depending on the circumstances. We'll talk about the circumstances under which you would give activated charcoal and the circumstances under which it could be dangerous. And then the third way you can prevent absorption of a poison is whole bowel irrigation. So using polyethylene glycol, or sometimes the product is called Go Lightly, and we might not have it in the children's wards, but usually the surgical wards have it because it's the bowel preparation. If a patient is going to have a laparotomy, a gastrointestinal surgery for whatever reason, then usually they'll have a colonoscopy, a gastroscopy, then usually they'll have a bowel preparation with polyethylene glycol, also called Go Lightly. And that can lead to an evacuation of all the contents of the bowel. And then removing the poison as well. But what you use depends on, as I say, when the poison was ingested, what type of poisons, because some poisons are not, some drugs are not absorbed by charcoal, and some should never be. You should never use charcoal or gastric lavage or any of those things, such as hydrocarbons. If a child's taking kerosene, if there's any risk of vomiting, then there's such a big risk of aspiration in those types of poisons, hydrocarbons, petrol, kerosene, etc. If it's a slow release preparation, then you're more likely to use some sort of product that'll reduce absorption. And as I said, is the patient drowsy or unconscious? Because with some of these ways to reduce absorption of the poison, if the child vomits, then that can be a big risk. Activated charcoal, as I said, is the most used absorptive agent, and it's highly effective against many drugs. So it absorbs many drugs and chemicals. Lots of different drugs can be absorbed by activated charcoal. It's not effective against a few, so you should never use it for iron or for hydrocarbons like kerosene or petrol, or for ethanol if a child's taken an overdose of ethanol, or corrosives. Charcoal won't be effective against that, or it might lead to vomiting that'll be more dangerous. But for drugs that do get absorbed by activated charcoal, it can be highly effective in reducing the absorption through the gastrointestinal tract into the bloodstream. Sometimes charcoal is combined with sorbitol, and that's a bit like polyethylene glycol, and that causes osmotic diarrhea. So after the charcoal, the child will then develop diarrhea, and that can help increase the reduce the transit time or increase the peristalsis of the gut, and allow for the poison to be evacuated more quickly. The dose is 1 to 2 grams per kilogram of the child's weight, and it can be either given with the child to drink it or with a nasogastric tube. But very important to protect the airway. You should never give activated charcoal in a child who is poorly conscious unless they're intubated and their airway is protected. Sometimes for certain poisons, it's useful to give more than one dose. I've given it for children who've had theophylline overdoses because theophylline has a enterohepatic circulation. That is, from the drug goes into the bowel and then is absorbed and passes through the liver and then comes back through the bile and then down into the bowel again and then is absorbed again. So it can circulate around. And so therefore giving more doses of activated charcoal every 4 hours can reduce the enterohepatic circulation of theophylline and then reduce the overall absorption. The same with amlodipine, the long-acting sustained release preparation. Usually you would give 2 doses of activated charcoal because it might be 6 or 8 or 12 hours before it's all absorbed, and so it can be useful to give a second dose. Whole bowel irrigation is useful when a poison can't be removed by charcoal, and again for slow release preparations, it's polyethylene glycol, which is a large sugar molecule that can't be absorbed through the colon. So you don't get absorption of polyethylene glycol. So therefore it causes a hyperosmotic effect. Water flows in from the gastrointestinal mucosa into the lumen of the bowel, and then you get an osmotic diarrhea. The child gets an osmotic diarrhea. It's a powder mixed with water. It doesn't taste very nice. It's not at all pleasant. So you'll have trouble getting a child or anyone to take it. So a nasogastric tube can be useful. It shouldn't be used in an unconscious child whose airway is not protected, because if a child vomits again, it's dangerous. And you don't need to give it if you're giving charcoal. Some people give it as a chaser for charcoal, but it's unnecessary. Usually the charcoal will do the job. But it still can be very useful, whole bowel irrigation for serious large dose poisonings. And then lastly, we talked about decontamination, reducing absorption of the poison through the gastrointestinal tract into the system. And then lastly, giving an antidote if there is one. For some poisons, there is a specific antidote that can reverse or limit the toxicity of the poison. Some of these are critical. Some of these are absolutely critical to affecting the toxicity of the poison, and some of them help a bit. So I've listed some that are quite critical if a child's taken a large dose of any of these medications. For paracetamol, if a child particularly, well, especially the types of poisoning that adolescents who are trying to self-harm or have a very substantial overdose, they may have taken 10, 20, 30 tablets of paracetamol. They certainly need N-acetylcysteine. That helps to replenish glutathione in the liver, and it inhibits the metabolic toxicity. There's a metabolite of paracetamol. Paracetamol itself is not toxic, but it gets metabolized when the cytochrome P450 system is overloaded. It gets metabolized to a toxic metabolite, which is usually very, very minuscule amounts of that are in the body. But when the system is overloaded by huge doses of paracetamol, then it can the toxic metabolite can cause liver failure. And it takes several days, as I said, 2 or 3 days to see liver failure usually. For iron, desferrioxamine, the chelating agent, can be very useful. And if you have that can be very useful. It won't necessarily reduce all the local toxicity, the mucosal toxicity in the gastrointestinal tract, but it will reduce the systemic absorption of iron, and therefore reduce the iron deposition that you can sometimes get if a child's taken a very large dose of iron. 100% oxygen is necessary for children who are exposed to carbon monoxide. It's like an antidote. Naloxone, of course, Narcan for any opioids, any morphine or pethidine or those fentanyl overdose, then Narcan becomes essential. There's another medication, a bit like Narcan, called flumazenil for benzodiazepines, which sometimes we give children who have respiratory depression related to benzodiazepines, and at other times you can just support their breathing for time, which is usually only sort of 8 or 12 or 24 hours at most. And then very importantly for organophosphate poisoning, for insecticide poisoning, atropine and pralidoxime, they're very important because organophosphates lead to a cholinergic toxidrome, where you have this overwhelming secretion of acetylcholine, and that can lead to toxic effects. So atropine blocks the acetylcholine. I'll explain that in a bit more detail. As I mentioned, earlier on, I gave a list of common poisonings, especially in tropical countries where often hydrocarbons and insecticides and pesticides and some household cleaning products are not as well maintained. And kerosene poisoning is a very common cause. And the main thing to know about kerosene poisoning is that it typically, as well as the skin irritation and the blistering of the skin, the main thing it does is cause an aspiration pneumonitis. This is a child who had kerosene poisoning. Again, any ingestion of that is if a child tries to drink kerosene, they usually don't drink very much at all. They only, because it's so unpalatable, they only may take a swig, drink a few gulps, but that's enough often because of the very low viscosity and the high volatility of kerosene and the very low surface tension for some of it to get in the lungs and cause mucosal injury to the lungs. It can, if there's a severe kerosene poisoning, lead to severe ARDS, acute respiratory distress syndrome, with severe hypoxemia. The children present with respiratory distress and hypoxemia and tachycardia, and you can smell the petrol on their breath, whether it's kerosene or whether it's petrol. You can smell it on their breath. And again, that kerosene or petrol poisoning usually occurs because petrol is stored in inappropriate drink bottles, sometimes even sold in inappropriate drink bottles, and that can lead to children mistaking it for Coca-Cola or some other drink. what kerosene and other hydrocarbons does is dissolve fats, and you've got fats in the lung, in the alveoli, surfactant. It can destroy the surfactant in the lung and lead to, as I said, ARDS, a bit like respiratory distress syndrome in newborn babies, but much worse than that, and leads to severe burning or damage to the alveoli and the bronchial mucosa. The children present with all those features, plus leukocytosis and fever. They often have a fever, and it's often mistaken for pneumonia, but you can smell the petrol on their breath, and sometimes there'll be telltale signs. The parents will know what the child's done, or they'll bring in the bottle. That I didn't mention that earlier on, but it's as part of knowing exactly what poison the child's taken, how much, and whatever. Please always ask the parents or the caregivers to bring in the product. They should bring in the blister pack of tablets, or they should bring in the bottle of tablets, or they should bring in the bottle of the poison, the insecticide, or the household cleaning product, and so you can know exactly what's in it. That's very important. Sometimes kerosene poisoning could lead to central nervous system effects. So sometimes seizures and ataxia if a large amount is taken, and sometimes that's because of the severe hypoxemia the child's had. I said before, but never induce vomiting or give gastric lavage or charcoal with any hydrocarbon poisoning, because there's such a high risk of aspiration. I've seen a child who ended up, because of the low surface tension, the low viscosity of hydrocarbons, given some syrup of ipecac to drink, and of course the child vomited, but the vomiting led to a severe pneumonitis, because having some petrol-rich vomit in your mouth can lead to an easy risk of aspiration because of the very low viscosity of the hydrocarbon. The treatment is really supportive care, so oxygen monitoring, careful monitoring of fluid balance. Most children with this sort of ingestion have taken a very, very small amount, and they almost always recover, but it can be worse if they have large vomiting or have more aspiration. I wanted to cover some other household poisonings, especially caustic ingestion, because most of the household products we use, bleaches and detergents, drain cleaners, household cleaners, many of them are caustic in nature. Some of them are acids, but many of them are alkalis, sodium hypochlorite, sodium hydroxide, hydrochloric acid, of course, but many of them are alkaline. And alkaline poisons cause tissue necrosis, especially progressive mucosal burns. So if a child's taken, for example, this household bleach, White King, if they've drunk that, then they'll get most likely mouth burns and esophageal burns. And I've seen a number of children who've had esophageal perforation or stricture from drinking this caustic ingestion such as this. If they've taken a serious ingestion, then immediately they get symptoms: mouth and throat pain, drooling, they'll start crying, they won't swallow, they'll often have vomiting and abdominal pain, and then later on you see much more swelling and mucosal erosion and burning of the esophagus. So the first thing to do is rinse the mouth in water as much as the child will swill in their mouth and drink. Don't pass a nasogastric tube in these children. Sometimes there's a nasogastric tube is passed, and because of the mucosal burn, then you risk having a perforation of the esophagus. A nasogastric tube does need to be passed in these children, but it should only be passed under direct vision usually by the surgeons, ideally with a gastroscopy, looking down to make sure the nasogastric tube passes smoothly and doesn't perforate the esophagus. If there's no person around to do a gastroscopy, then passing it with lots of lubricant in very carefully controlled conditions is important. It is important if a child's got any mouth or oral burns, then that at some stage a nasogastric tube is passed, because if they've got esophageal burns, then they will end up with severe stricture, and it's possible for a nasogastric tube to bypass that stricture. But again, it should only be inserted under direct vision, if at all possible. Yeah, most accidental ingestions occur in children, being they are very minor. If they've taken just most bleachers, then they can be quite dilute, and usually the child doesn't suffer much apart from getting some mouth erosions. But if a child with vomiting or refusal to drink or has mouth erosions, then they need to have an endoscopy, and you need to keep them in hospital and organise with the surgeons to do an endoscopy to just look at their esophagus. Some ingestions occur in adults, in adolescents, and they can be quite severe because the child hasn't just taken a quick one sip of the ingestion, they've taken a larger volume, and they can have quite severe esophageal burns. Strictures tend to occur over weeks or months, and they can lead to chronic pain and malnutrition. And the only way to deal with that is to pass a nasogastric tube under direct vision and then make sure you maintain the nutritional state of the child. Most children don't have severe strictures. It may not even have esophageal burns, but about 20% of children who had, in several studies, who had severe ingestions develop strictures by about 3 months of their esophagus. It can be very, as I say, disabling because of the chronic pain from it and malnutrition. The key message is that most household bleachers don't cause severe toxicity, but when they're taken in large amounts or by young children, they can. And another household danger are these button batteries, and they are similarly corrosive, and they can corrode they can lead to esophageal corrosion of the mucosa, and can lead to perforation of the esophagus, or even erosion into the aorta, which passes posterior to the esophagus. That they need to be urgently removed. A button battery that is there for 4 hours can lead to esophageal erosion and esophageal perforation. So if you see a child with who might have taken a button battery, get an X-ray, because it's always radio opaque. And sometimes these are mistaken for a coin. People think the child's ingested a coin, but very important to look to see if it's a button battery. Usually a coin does look different because of the smooth edge of the button battery compared with the slightly irregular edge of a coin, which has some indentations on it. I wanted to just briefly discuss naphthalene, another cause of poisoning. I mentioned before that naphthalene or mothballs, these are also, the small lolly-looking products that are put in toilets to clean toilets. They have a similar effect. They can lead to severe anemia if a child ingests naphthalene. And you can imagine this is from Amazon. This is how naphthalene is marketed by Amazon. You can buy packets of 50 or 100 of these, and they look just like sweets, don't they? Like lollies. And it's not surprising that naphthalene is a common cause of poisoning in children. It can lead to anemia from haemolysis, more commonly if a child's G6PD deficient, just like with Primaquid, for example. But in any child can get naphthalene-induced hemolytic anemia, and also methemoglobinemia and acute kidney injury. So children can have kidney failure from naphthalene ingestion. Regarding the hemolytic anemia, the only treatment for it is blood transfusion and monitoring of the child closely. If the child's got hemoglobinuria, that is, they've got hemoglobin in the urine, then giving alkalis can be useful to alkalinize the urine. But in a child who's got renal failure from a naphthalene ingestion, then some sort of renal replacement therapy, whether it's peritoneal dialysis or hemofiltration, becomes necessary to support their organ systems while the poison resolves. I mentioned mosquito coils. You've all seen these and probably used them. They can be quite dangerous if a toddler, if sometimes the little particles break off. Remember I said toddlers everything goes hand to mouth, and they can lead to quite significant ingestion, mouth ulceration, or and also some gastrointestinal and central nervous system effects from mosquito coils if they're ingested. So they can be quite dangerous too. So again, all these household products, button batteries and household cleaning products and mosquito coils, they need to be kept out of reach of young children who go hand to mouth with everything. We talked a bit about paracetamol, and I just wanted to emphasize what a common cause of childhood and adolescent ingestion paracetamol is. It is a rare cause of death. Most people, most children and adolescents who ingest paracetamol don't die. It's a rare cause of death. And if a child gets treated within 8 hours, then survival should be 100%. No child should die of paracetamol ingestion if they're treated with the right antidote, N-acetylcysteine, within 8 hours. But if they don't get that treatment, then they'll get liver failure within 2 or 3 days. There is a higher risk among some children, in children on anti-epileptic drugs, in children with malnutrition, because they have baseline glutathione depletion in their liver anyway. But the reason why paracetamol causes toxicity, as I said, mostly when we take some paracetamol, it becomes conjugated to a non-toxic metabolite, and it's excreted in the urine. Normally 5% of it becomes metabolized to a dangerous compound, and that's NAPQI, and that then is mopped up by glutathione in the liver. Glutathione is there's usually enough sources, sufficient sources in the liver to mop it up, and then it gets conjugated to a non-toxic product, and therefore the paracetamol is not dangerous. But in the setting of paracetamol toxicity, this process becomes overwhelmed. That is, there's glutathione depletion, and this process of conjugation to a non-toxic product is overwhelmed. And so more of the paracetamol ingested gets converted to this NAPQI, which is the toxic metabolite which causes liver failure, and there's no glutathione, so therefore it causes toxicity to the liver. And all N-acetylcysteine does is leads to repletion of glutathione. This product in the liver product in the liver that mops up the excess of this NAPQI, the toxic metabolite. So it's useful I think it's important to know the mechanism of action of N-acetylcysteine. It replaces glutathione in the liver, and therefore the paracetamol that's been ingested can be safely metabolized to a non-toxic product. And as I say, if that's not available, if a child presents too late, if they've had a large ingestion, then what you'll see over the coming 2 or 3 days is a rise in their abnormal liver function tests, so a higher ALT, and eventually their INR, their coagulation, will become abnormal. And usually the INR is the best index of whether or not a child's going to have severe liver toxicity. The prothrombin time, or the INR, will tell you that, or the ALT rising to above 1,000, etc. The treatment for it, as I said, is N-acetylcysteine. Ideally, you need to measure the blood level of paracetamol. If you can't lab can't measure the blood level of paracetamol, then giving N-acetylcysteine anyway is very safe. It's a very safe medication to give, and the way you give it is, well, if you can measure the level at 4 hours, then there are certain levels under which you don't need to give it, and then certain levels above which you do. And there's what's called a nomogram, which is a graph that describes at what level of paracetamol in the blood N-acetylcysteine should be given. If you don't know the dose of paracetamol that was taken, and you don't know the timing, and you can't measure the paracetamol levels, then giving N-acetylcysteine for 24 hours is a very safe thing to do, and monitoring the liver function would be what you do. This is like a nomogram of paracetamol ingestion. If you can measure the levels, then the protocols suggest you should measure at 4 hours. If the level is under a certain level, if it's under 1,000 at or under 150, there's two ways you can measure paracetamol, either as micromoles per liter or milligrams per liter. And it's very important to know which your lab, if they can measure it, which they measure, and plot the nomogram appropriately. Mistakes can be made if you plot the nomogram according to one and you think it's the other. So if your level of paracetamol is below 150 milligrams per liter, then at 4 hours you don't need to give N-acetylcysteine. If it's above 150 milligrams per liter at 4 hours, or if, for example, you see the child at 7 hours and it's above 600 milligrams, 90 milligrams per liter, then you need to give N-acetylcysteine. And if you, as I say, if you can't measure paracetamol levels, or you don't know the timing of ingestion or the amount of ingestion, but you believe the child's taken a substantial dose of paracetamol, then usually it doesn't occur from 1 or 2 tablets. This is usually a very serious ingestion done by typically an adolescent who's trying to self-harm. Occasionally it's done by a young child, but typically an adolescent who's trying to self-harm. Then giving N-acetylcysteine for 24 or 36 hours is a very safe thing to do. I wanted to just briefly touch on organophosphate agents, because they have a different sort of toxicity. And these are insecticides or pesticides. They can cause poisoning because they can be absorbed through the skin, or they can be inhaled, or they can be ingested. And most of the severe poisonings come from ingestion particularly. And as I said, they lead to a cholinergic crisis. They lead to a massive increase in acetylcholine available at the postsynaptic membrane of the neuromuscular junction, because they inhibit acetylcholine esterase. And acetylcholine esterase is the enzyme that breaks down acetylcholine. If you don't have that enzyme, then you have a marked increase in acetylcholine. And that leads to, as you remember, acetylcholine stimulates both muscarinic and nicotinic receptors in the body. And muscarinic overactivation leads to increased salivation, lacrimation, so lots of tears, urination, hyperperistalsis of the gut, diarrhea, bradycardia, and hypotension. So it has cardiovascular, gastrointestinal, and secretory effects. Whereas nicotinic overactivation leads to coma, muscle twitching, muscle paralysis, often muscle fasciculations, tachycardia, and pinpoint pupils. Pinpoint pupils gives it away often. The children will have the tiniest pupils and hypersalivation often. The treatment for it is a competitive antagonist of acetylcholine, which is atropine. You just need to keep giving atropine while the child has this hypersalivation. There was a case of this organophosphorus insecticides ingested in Rabaul recently, and this was treated very well by the team in Rabaul with atropine and pralidoxine, but particularly atropine, over about 4 to 7 days. I think there was still needed some atropine even up to 5 to 7 days, but it was managed very well. The child had a full-on cholinergic crisis and needed mechanical ventilation for 7 days and many days of atropine in administration, but the child recovered and was perfectly fine after that. So these insecticides or pesticides that a child might ingest, and because it's being kept in an inappropriate container or there's not adequate safety, can be very dangerous, but they can be managed with antidotes that are available. Now, as I said, there are hundreds and hundreds of poisons, and it's impossible to know all about them, all about each one of them. But there are very good resources online, and there are many different resources online. Some you have to pay for, and some are free. I just point you to there's many, but I point you to the Royal Children's Hospital Clinical Guidelines for Poisoning. It's the Acute Guidelines for Initial Management of Poisoning. This is the Royal Children's Hospital in Melbourne. It lists maybe 30 or 50 different poisons and specific treatment of those poisons. I've talked to you about some other poisons that are not so common that they're on this guideline, but insecticides and pesticides and kerosene and organophosphates, etc., corrosives. Many of these are on this management guidelines. I'd encourage you, if you get a child who's taken an ingestion, to look up their what to do in these guidelines. I think they're very useful and quite well written. But as I say, there are other guidelines around the world that you can probably find. I hope that's been useful. Again, we can't cover everything about poisoning or ingestions today, but at least to know what the general way to manage these patients is and what the specific ways you need to manage certain common poisons. So I'm going to stop there, and thanks for your attention today. If there's any questions, I'm happy to answer them. I'm just going to stop the recording, and then I'm happy, as I said, to answer any questions that you might have. Thanks very much.